All right, thanks everybody. Appreciate you joining us today. And for those of you, if you have colleagues who can't, just remind them that a recording will be circulated later and available on our YouTube page. So today we're going to talk about the Interim Canada Dental Benefit, and I'll be speaking about uptake of the program during the 21 months of that before the arrival of CDCP. And Thiago is going to look after sharing results from a survey that we did of dental providers in 2023 and 2024 about views on the Interim Canada Dental Benefit. Okay, so just some disclosures here. I wear a few different hats. I received some grant funding from different agencies. No conflicts of interest though, but just thought I would disclose those. And I just want to make mention that we acknowledge we're gathered on Treaty 1 territory. It's the homeland of the Red River Métis and the ancestral lands of the Anishinabeg, Anishinaabe, Dakota Oyate, Denezuline, and Niniwak nations, and that northern Manitoba includes lands ancestral to the Inuit. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to listening and respecting traditional teachings regarding oral health. Our research team and Healthy Smile, Happy Child initiative are committed to building relationships with First Nations, Métis, and Inuit communities to incorporate Indigenous knowledge in our research and health promotion efforts. And by addressing the oral health disparities faced by Indigenous children, we strive to continue advocating for the oral health of all Indigenous children, their families, and their communities, fostering trust through transparency and respect. And so I'll share now just on some evidence that we have now after looking at the uptake of applications from parents for children under 12 years of age in Canada. So I am funded through, as Daniela mentioned, the Canadian Institutes of Health Research Applied Public Health Chair in Public Health Approaches to Improve Access to Oral Health Care and Oral Health Status for Young Children. And as part of the program, it really focuses on access to care. And you'll see that there are 6 key domains to access to care. There are the structural barriers, which include accessibility, availability, and accommodation. There's definitely the affordability piece, which falls under financial barriers. And lastly, those personal and cultural barriers, awareness and acceptability. So with aim 2 of this program of research over the next 5 years, we are looking at our evaluations of the interim benefit, even though it has now sunset, and as well looking at doing evaluations of the newer Canadian Dental Care Plan and looking at the affordability piece, but also looking through interviews with individuals, clinicians, and families, trying to understand the acceptability and awareness aspect of oral health care access and the programs. So as you obviously know, if many of you are from dental settings, the interim CDB, as we'll call it, was only for children under 12 years of age, for children from households under 90,000 net income. They needed to not have access to private insurance, and this was funding that was directly paid to families, so that this way families could pay the out-of-pocket dental care expenses during the period. And to be eligible to apply, they needed to have up-to-date income tax filings with the Canada Revenue Agency. And as well for this, one of the sort of criteria that distinguished if you were eligible or not is if families had already qualified for the Canada Child Benefit, just because that's also the same income categories are considered. So basically families received either $650 per child if they were earning under 70,000 net, 390 for those between the 70 and 79,999 range, and those earning 80 to 90,000, each child received $260. And so we've got here sort of the two plans and sort of when they overlap. And so year one of the Interim Canada Benefit, remember it sort of was announced March of 2022, but by the time it actually got implemented was October of 2022, and year one sort of concluded June 30th of 2023. And then year two of the interim CDB then ran from July 1st of 2023 to June 30th of 2024, at which time it sunset. And the applications for children under 18 for the CDCP began, or they opened up June 27th of 2024. So with this, we have information as well on the CDCP, but I'll sort of, for the sake of time, hop over that for now. So our purpose looking at the Interim Canada Dental Benefit is we wanted to analyze the aggregate data from Government of Canada on applications made and accepted during the entire 21 months of the interim CDB, to evaluate its reach, to gain insights into dental care needs and barriers faced by low-income Canadian families. And so what did we do is, so data were available from the portal of the Canada Revenue Agency, and we looked at two time periods. The data that were released for the first year, or the first period, wasn't a full 12-month period of time, but period one and period two, which ran from July 1st of 2023 to June 30th of 2024. And we looked at descriptive statistics, looking at the number of applications, unique applicants, and amount distributed by government. And then we also then went on to calculate rates of participation using population data from Statistics Canada. And then we adjusted rates, and we'll see in a few minutes, based on whether or not children came from households without private dental insurance. And then separately, we also then looked at just limiting the rate calculations to those who had no private or public insurance. And then maps were generated using MapChart. So over the 21 months of the interim CDB, there were 452,000 plus applications made. More applications seem to be made during that shorter period one window, which was only really 9 months, compared to period two. As well, over 440 million was distributed to families as aid in payment for them to pay for out-of-pocket expenses. But interestingly, more funding was distributed in period two. And part of that also was families who had applied in period one, but needed additional funding to pay for expenses that went beyond the $650 that were first allocated per child. Overall, there were 321,000 children receiving the interim CDB in period one, and 328,000 receiving the interim benefit in period two. So if we look without sort of looking at sort of the number of people per population and the number of children under 12 in these different provinces and territories, just on sort of the broad data that we had, Ontario, Quebec, Alberta, and British Columbia had the highest numbers of approved applications and participants. And that's not really surprising, considering the sizes of those provinces with regards to populations. Ontario consistently led across all periods, and the most amount of money were distributed to families within Ontario. Quebec actually saw a slight decline in the number of applications between period one and period two. And if we just look overall at the sort of overall sum of applications, there were very limited applications from the Yukon, from the Nunavut territory, and the Northwest territories. This figure here sort of just visually presents the data for you. The orange represents the number of children. The blue represents the amount in thousands that were distributed. The lighter shade of blue and orange speak to period one, and the darker colors speak to period two. So the greatest number of children receiving the Interim Canada Dental Benefit in both period one and period two were 6-year-olds. we were very pleased to see that there were increases in infants and younger children receiving the interim CDB between period 1 and 2. So for instance, amongst those under 12 months of age, there was a 19.8% increase in the number of recipients, and also a 20% increase in the amount of funding that was given to families for children under 1 year of age. Amongst 1-year-olds, there was an increase 7% wise in the number of recipients, and almost 9% increase in funding for the 1-year-olds. And I think it's just remarkable. I think it maybe shows a lot of the efforts that you and your peers have been doing, and associations professionally in different parts of Canada promoting the importance of early visits for young kids is maybe paying off in this respect with a lot of money and a lot of uptake. The decrease is not surprising amongst the 11-year-olds, as this program was only up to 11 years of age. So we're not overly surprised that sort of the number of 11-year-olds decreased from period 1 to period 2, as well as the amount of funding allocated. So I'm going to now move into the rates, because if we look at just the overall data, it was showing Ontario, Quebec, BC, Alberta, huge uptake. So what we did is we adjusted for the overall population size in each province and territory for the number of children 11 years of age and under. And if we look for sort of adjusting these are better ways to sort of present the data. So for just adjusting, just based on population statistics alone, the provinces in period 1, which is on the left, period 2 is on the right. In period 1, Ontario and Manitoba had very high uptake of the Interim Canada Dental Benefit, and Nova Scotia and Saskatchewan not far behind. And in period 2, Manitoba, Ontario, Nova Scotia, and Saskatchewan had high uptake. The darker blue shade indicating more uptake, the lighter blue sort of showing lower proportion of uptake by province or territory. But realizing, okay, this is every child in this age group, is that the right sort of denominator to use? So what we did then is we moved on to look at adjusting the rates by looking now at children without private dental insurance. So trying to look at those where there was no sort of work insurance and using that as the denominator. You'll see that Nunavut, Northwest Territories, Yukon, there's no data presented because in the Statistics Canada database, there is no information to run this calculation. But what we find is for using that denominator now for amongst children from families without private dental insurance, again, Saskatchewan, Manitoba, PEI, and Ontario had higher uptake than other provinces in period 1. And in period 2, we have Saskatchewan, Manitoba, Nova Scotia, and Ontario having higher uptake proportionally compared to other regions of Canada. So, and then lastly, what we want to show is we then also went to look at, well, what if we look at the number of children per province or territory from families without private or public insurance, because these are probably the most at-risk kids who may be falling through the cracks. And so this is now where we start seeing high uptake in certain parts of Canada, including the north. So in period 1, we had very high uptake again in Nova Scotia at 673 per thousand if we convert rates, and in the Northwest Territories, 618 per thousand applications from there in period 1. And then again, sort of showing again high uptake in Saskatchewan, Manitoba, Ontario, and Newfoundland. And in period 2, this is where we see, a really remarkable jump in Nova Scotia to 717 per thousand applying, and then high numbers in Saskatchewan, Northwest Territories, and Nunavut. So when we do these adjustments for looking at how many children from families without private or public, this is encouraging to see that when we look at really just the crude data, we sort of got discouraged and thought there's relatively low uptake in the territories, but this actually then lets us know amongst those who really need it, the uptake is much higher than other parts of Canada. So lastly, just to sort of share with you, in period one, again, we found that almost 47% of children were from families earning under 30,000. So they were getting the full 650 dollars per child. So again, it sort of tells us that maybe those most in need for this program were applying. 45% were from those between 30 and under 70,000. And in period two, the really low income families applying increased almost 10%. So that's encouraging. And the other percentages there. And then lastly, we just wanted to look at based on the first 18 months of the data, we had made some predictions in that one paper that we were going to see more sustained uptake in the last quarter of the interim CDB. But in fact, we actually found that there were 26,910 fewer applications than projected. There were 26,747 fewer applicants and 48,000 fewer children who received in that last quarter of 2020, or the first quarter, I guess, of 2024, but the last quarter of period two, and also $30 million less distributed. And this we really theorize is because of the arrival of the CDCP that started on June 27th, 2024. So I'm going to turn it over now to Thiago. I think we're just going to rejig the screen a little bit. Yeah. And he's going to continue on talking about dental providers' views on the CDB. Oops. Okay, just give me 1 second here. There we go. Okay. Hi, everyone. I'm Thiago. I'm Dr. Thiago Baltus, and I'm going to talk a little bit about the dental provider views, the work we've done with them. So just to highlight what Dr. Bob said, the Interim CDB was a benefit for children under 12 years old. I'm not going to dwell into this because he talked enough about this, but I just would like to highlight that it was a cash benefit. It was a cash compensation for families with the annual income up to 9,000. So as he mentioned, it's $650, $390, and $260 per child, per eligible child. Speaking of eligibility, so when parents went to the website, although now we can see the benefits closed because it's being taken over by the CDCP, parents will have to meet the eligibility criteria that we talk about a little bit past. So, but when they looked at the website, it looked like a little bit like this. I'm not going to go over all of them again, but just so you have an idea. So they had this checklist and they had to be, they need to check all of them to be eligible for the interim CDB, which was a total of 9 criteria. So this is an image, what is most likely the parents look like, what they felt like. Daniela? I'll present that one. Okay. Sorry, everybody.
We can't see the slides.
No?
Oh, no, we can.
Stop share. Maybe stop share.
Is it working now?
Yeah. Yep.
Sorry, everybody. Okay, moving on. Okay. So I'll move on. So this is what a parent or a caregiver look like. Most likely after seeing all this criteria, they most likely had a lot of questions, a lot of confusion might have happened. So it's very likely that by the end of the day, they'll ask the dental office, they should know what to do. So based on that, in addition to that, we do have some papers, we do have some studies on the interim CDB and views of interim CDB, but we still don't have any perspective from who provided the care. So that was the goal of our study. So the goal was to look at the oral health professional's opinion. And in order to achieve this goal, we had discussions within our group based on the clinical experience, based on previous studies, and based on the strategic council survey that was administered by Health Canada. And then we came up with the survey tool, aka a questionnaire. Okay. So this questionnaire had 7 different sections and it had 44 questions. So it's quite a large questionnaire. So included demographics, awareness, application, receiving the ICDB, using the ICDB, challenges, and suggestion. Okay, so what did we do with this questionnaire? Well, we submit through Microsoft Forms. We generated an electronic version of it, and then we sent to oral health professionals from Manitoba, so dentists, hygienists, dental therapists, assistants, and receptionists. And we sent them an email that looked a little bit like this for inviting them to participate. So once they accepted our invite, they submitted back their anonymous answers. And he used Excel and number cruncher statistical software in order to proceed with the analysis and to generate the graphs. Okay, so these were our methods. So from now on, I'm going to give you guys a general idea of what our results look like, because as I said, there are 44 questions. I cannot go for the sake of time to every single question, so otherwise it's going to be too long. So to have a better and a general idea, looking at the demographics on the section 1, most of our respondents were women, over 80%. The main position, the main role that responded were dental assistants. The highest number of years in clinical practice, these are means, are from dentists and dental hygienists. And the most people were working on urban offices, 77, almost 78% of them. Okay, and I just didn't want to highlight, although we had dental therapists, only 7 dental therapists joined our study. As I'm moving forward, I'm going to show results all in percentages, and they might show some very different percentages for the rest of the other roles. But since there's just 7 people, it might be a little misleading, but I think you might understand what I'm trying to say in a minute. Okay, so section 2, awareness. Awareness was the biggest, the largest portion of our questionnaire. It comprised, I think, 19 questions, if I'm not wrong. And as you can see, in a general sense, even in total and among all the roles, awareness was high. So people were aware that existed the benefit, right? But moving on, we asked on how did they learn about the Interim CDB. So we had modest response on family, friends, TV and radio, social media, newspapers. And this is just, I want to make a note here for federal government communication website or CRA website. We see that there's 71% of dental therapists there, but it looks like a lot, but it's actually 5 people out of the 7 that responded. That's what I meant by misleading. So, and then modest from patients as well. So when we moved on to the associations, MDA, the Manitoba Dental Association, was very high, especially among dentists, dental receptionists, and assistants. The College of Dental Hygienists of Manitoba naturally had the highest knowledge rate from dental hygienists, and Manitoba Dental Assistant Association had the highest on dental assistants, although we had more dental assistants learning about the ICDB from the Manitoba Dental Association than the MDAA itself. It's just curious. Okay, so just to wrap up awareness, that's the last question I'm going to show you about this. We asked if they found the information provided by the government was clear. So we had a modest rate of answers, people saying yes, but I think it's more impactful to show how many answered no. So all of them actually responded, over 50%, so majority of all rows said that information was not very clear. So that's going to be important later on when we reach the conclusions. Okay. Section 3 was application procedure. We asked how how knowledgeable they feel about the eligibility criteria, the ones I showed before. And we had 4 answers for this. We had a lot, somewhat, very little, and not at all. But we merged together a lot and somewhat in a group, and very little and not at all in a different group. So we have a better idea on how these were distributed. So blue shows a little more in the sense of more positive balance, and orange in the more negative balance of the knowledge sense of things. So we can see that there's a lot of weird and a lot of variability going on here. Okay, so for section 4, receiving the ICDB, we ask if their amounts that were given by the benefit were enough to cover the costs for their patients. And interesting enough, more people and more professionals, instead of saying just no or yes, very high rates on they don't know if the amounts were enough or not, which shows that maybe they're not involved in the payment, or maybe there's something else going on. Okay, section 5, using the interim CDB, we asked how confident they felt about providing information about the benefit. And then again, more people going towards not confident or maybe confident. So this shows us how people were very few people were very confident about giving information about it. So that may speak for, okay, so why are they not feeling so confident about giving information? Do they have the information? Did they understand what's going on? But we're going to address this later. So second to last, section 6, we're talking about the challenges, if they had met any challenges assisting the clients on ICDB. And then again, we had a lot of high rates. Speaking of, that's not applicable to me. So we couldn't tell if they didn't have challenges, or they didn't assist, or they didn't have any clients applying for the ICDB, but that's interesting. And the last question for this part is a suggestion for ICDB. So they ask, do you believe that funds should be paid directly to the clinic, such as a regular insurance policy, instead of being a cash payment? Remember that I mentioned, I highlighted it being a cash payment. So here we had a massive positive response from everybody. So maybe we can infer that maybe they had some trouble with parents and caregivers managing the money in order to do the payments, which speaks, we may take a look at this later too, but that's an interesting result. Okay, changing gears a little bit. Instead of looking at roles itself, now we're going to talk a little bit about the area of office. I'm just going to show you these 2 results, which are very interesting. So when he asked if they think the benefit improved access to oral health to young children, we had a massive difference from professionals from rural area compared to urban ones. Massive. So P value was really low. So rural professionals were very eager about the benefit improving access to children. And then when we ask if they're encouraged parents and caregivers to apply for the benefit, we also observed a difference between rural and urban, more higher in rural professionals. Still significant, although not as strong as the first one, but still very significant. Okay. And for the last, I'm going to talk a little bit about the multivariate logistic regression, which is a fancy way to ask what are the odds. So we developed 2 models of logistic regression. Logistic regression is going to tell us what are the odds of having this variable interfering with the other variables, or what are the chances of I having this answer, setting aside all these confounder factors. So I'm no statistician whatsoever. So I'm learning, I'm doing my best. So I'm just gonna try to give you guys an overview how we interpreted this. For the calculation of the multivariate logistic regression, there's a log and exponential, and there's crazy things going on, but I'll try to simplify just for the sake of make things easier. Okay, so if you look at the bottom of the screen, when you talk about 100% of something, let's say how many times if I toss a coin up, how many times, or hold on, let me rephrase that. If I toss a coin 100 times up on Earth, how many times the coin goes back down? Well, 100 times will go back down, right? So 100 out of 100. That's technically what 100% says. And going a little bit more technical, if you divide a number by itself, 100 by 100, you always have 1. Okay, what does it have to do with odds ratio? Well, you're just going to use this to explain how we interpreted this, the odds ratio. So when I have an odds ratio higher than 1, means that some event is more likely to happen. And when I have an odds ratio lower than 1, means that that event is less likely to happen. Okay, considering significant results. So looking back at our model on the top, we see, oh yes, thank you. So for the first model, we use the question, have you encouraged parents and patients to apply for the interim CDB? So when we use the confounder factors, number of years of practice, gender, area of practice, and the roles, we notice that urban professionals from urban areas had a lower odds ratio of answering yes, so of encouraging parents or caregivers to apply in comparison to the rural counterparts. So it's the same or similar what we just saw in the previous slide, but this is even better because it takes away other confounder factors, so it still stays significant. So it's really important. It's a really interesting finding. And moving on, we noticed also there was a difference between hygienists and dentists. So it was the interpretation, so lower odds, it's less likely for you to find a hygienist encouraging parents to apply for the ICDB in comparison to dentists, but comparing hygienists to assistants, they had a higher odds, so they're 50% more likely to encourage parents to apply in comparison to assistants. Okay, so the next model is the same rationale. We ask the question, do you believe that ICDB improves access to oral health care for young children? So we noticed the significant difference between gender. So we had a lower chances or lower, so it's less likely for male practitioners to believe in the benefit ability to improve the access to oral health. But that might just speak for the massive difference of participants we had. We had like over 80% of females. So it maybe we're trying not to get to any conclusions here because of this big difference. But then again, we saw a very low odds, 50% less likely for urban professionals to believe that the ICDB improved access, or interpreting this in a different way means rural-based professionals were 50% more likely to say, okay, yes, I do believe the ICDB improved access for young children. So to wrap things up, the conclusions we got was we observed a big variability among the results when we were compared to roles. And for several instances, we noticed there was somewhat of a low quotation marks there, engagement. So there are a lot of questions that personnel answer like, oh, I'm not confident. Oh, this is not applicable to me. I don't know the answer for this. So these two findings, they speak to us that perhaps the main reason they're not as engaged and maybe they had such a variable answer because they may have not been properly informed about the benefit. So as Dr. Bob said before, the benefit was announced in March 2022, and it was fully deployed in October the same year. So it gave the governments, give or take, 7 months to prepare. So maybe things were a little bit rushed, and maybe the communication was not ideal between the professionals and the government. Aside from that, even with these problems, the ICDB was very well received, especially for as we saw in the rural based professionals. So which shows us, even after correcting for confounder factors, which shows us that support for dental care is in big demand. And so just to do a summary here, we did notice that awareness was high among all the interviewed personnel, but they seem to be very underinformed. So information downstream may be spread in an uneven and insufficient way. And the differences between areas of office indicates that people in rural areas are in great need of oral health care support for both access and financially speaking. Okay, I'm going to pass the torch back to Dr. Bob.
Okay, thanks everybody. And then so just sort of where are we going next directions with this is, so now with the launch and arrival of the Canadian Dental Care Plan, we're funded to continue on this research. So we are currently doing surveys with parents about what they know about the Canadian Dental Care Plan, and we'll also undertake some qualitative activities. We hope to as well be able to do the same with dental providers, a similar survey like Thiago spoke about with the interim CDB. We'd like to repeat that and maybe do it a few times to sort of see how attitudes have changed. I think there's been a shift probably. There was a lot of concern amongst providers as CDCP was being rolled out, and now we see many offices accepting CDCP. So there's probably been a shift in the last 6 to 9 months in that program in views and how it's improving access to care. We also hope to look at, just like we've looked at the rates of uptake for the CDB, we are planning to as well, and waiting for data to arrive for children under 18, looking at seniors as well, and then adults with the valid disability tax credit, those 3 distinct groups. And then with time, once dental claims data become available, those discussions have started, so we can begin to look at what dental procedures are being billed for the different age groups, and then eventually looking at the future downstream effects of CDCP, such as will that lead to maybe more early care for kids and less demand for dental surgery, although probably initially there might be an increase in the demand for dental surgery as maybe kids in need who have gone without care finally get picked up and families can access care. And then as well, what is the benefit in the long term with maybe improving and reducing the number of dental related trips to the emergency room. We want to thank our funders, specifically here where we're based at the Children's Hospital Research Institute of Manitoba, home base of our lab, but also as well, mostly for this project. We could not do it without the support of the Canadian Institutes of Health Research, and really thank them for the support. Our different partners and different projects, our current research staff, we thank them all for involvement and participation, and then just a listing of our lab members, staff, collaborators, and just a photo of the